Well, today we're going to talk a little bit about hallux valgus surgery and talk about some of the biomechanics that Michael Burns had talked about. And also, hopefully you read the articles that I had sent. Before we even get started, I just want to talk a little bit about, there's two articles in particular. One is the Faber article, which was a 10-year follow-up on it's a randomized controlled trial, a study of Hohmann distal osteotomy and Lapidus fusion. And they measured the best they could prior to the randomization, whether or not there was hypermobility of the first ray. And after they found all these patients with hypermobility, they then randomized them into distal osteotomy and Lapidus, and then followed them for 10 years. And without going through everything that they said, the bottom line was that they concluded that, first of all, there was no difference between the distal osteotomy and the Lapidus in terms of a recurrence of hallux valgus, despite the fact that there was not a fusion at the TMT joint. And that their opinion at the end was they weren't sure that hypermobility was even an issue when it comes to recurrence of hallux valgus in relation to fusion of the TMT joint versus realignment of the joint and the soft tissues around the joint. So it's just an interesting level 1 study, which is very rare for foot surgery, randomized controlled trial looking at Lapidus versus distal osteotomy. You're not going to find that in any of Paul Dayton's articles or any of these other articles that we read about hallux valgus surgery. So I thought that was an interesting article. It was really I think a watershed study, a level 1 study to really points to the idea that hypermobility of the first ray or the first metatarsal is probably multifactorial and may not be necessarily cured by TMT joint fusion. And so that's what we're going to talk a little bit about that, about what makes TMT fusion fix a hypermobile first ray when we're not sure that dorsiflexion of the first metatarsal even has much range at the TMT joint, and that range of motion may actually occur more proximally than the TMT joint. So that was an interesting article. And the other article I sent you was basically the opposite, which was Paul Dayton, who I know very well. He was on our committee for foot surgery when I was the chairman of that. And his article, which was a level 5 study, by the way, talking about derotating the first metatarsal to get sesamoids back into alignment. That is a very interesting approach, and really does not take into account, in my opinion, the pathoanatomy of hallux valgus. And so I want to show you a little bit about that as well. So that's sort of where I want to take this. So unfortunately, I get no compensation from anyone, and I have no conflicts of interest. Maybe someday I will, but not today. This is my feelings on PowerPoint. Not a big fan. I think that it's difficult to transmit information, and it's basically not a great learning tool, but that's a personal opinion. The other thing I want to talk about is evidence-based, or I call it evidence-biased medicine, okay? So, and this is basically what I found over the years. If you've got an evidence-based article that you don't agree with, and it doesn't agree with your experience, you simply ignore it. You just don't want to hear about it. If you disagree with it, you'll criticize the study. It's not level one. I'm not gonna believe it. But if the evidence-based medicine agrees with you, then you can quote the study no matter what its design flaws are, because you already know it's true. So basically, evidence-based medicine fits better for medicine than it does for surgery. Surgery is difficult to have blinding. They're rare to have. It's rare to have randomized controlled trials. Although I did show you what I thought was one of the better ones that I've ever seen in especially in foot surgery. So I think there's so many unanswered questions about hallux valgus, and I think we ought to just look at those. What's the etiology of hypermobile first ray? Is it really a TMT joint hypermobility? Is it secondary to first metatarsal phalangeal joint instability? Is there transverse arch instability, which is a newer concept, which we'll talk about? What's the natural history of intermetatarsal angle deformity? No one's born with a high IM angle, or you just never see little kids with high IM angles. That is a deformity that occurs over time, and you don't see angular deformity in the first metatarsal to cause high IM angles. This is a secondary type of deformity that occurs, I think, from instability of the first metatarsal phalangeal joint. Where's the lesion? What's the nature of the IM angle? Just like bunions are positional and structural. They still teach that, positional and structural deformities of the first MPJ. Sort of like structural would be a high distal or proximal articular set angle, or a long first metatarsal. Those are structural deformities. But positional deformities, you can't measure any angular deformities of the metatarsal or the phalanx, but you have a high hallux abductus angle, and it's more of a positional abnormality. And I think, and I've written some articles on this, that the IM angle comes in those also in positional deformity and structural deformity. And so we want to just look at that and try and determine whether or not, or look at some films and whether or not you can determine preoperatively whether or not an IM angle is a structural deformity, which requires some type of structural correction, or is it a positional deformity, which would reduce once you reduce the angular deformity at the MPJ and the issues around the sesamoids. So in order to understand all that, you sort of have to have some understanding about the anatomical structures that stabilize the first ray. But before we do that, let's just look at this. So Ryan, do you know what causes something like this?
Talking about like laxative.
It's a valgus ankle. This is a torn deltoid ligament. Okay, this is a deltoid ligament injury. So you tear the deltoid ligament, and your foot becomes hypermobile in the ankle and goes into valgus. And so ligaments are key medial restraints in the foot. Okay, you can have other problems. You can break a malleolus and get this, or you can have other issues. But this was strictly a deltoid ligament injury. And so these medial ligaments are critical for the medial restraint systems in the foot. So if we move down from the ankle to the talonavicular joint, the blue arrow is the posterior tibial tendon. And this is on the left side. You see these two little white arrows. This is a normal spring ligament. And on this side, there's a torn spring ligament. If you tear your spring ligament, or if it becomes attenuated, you develop an adult acquired flat foot with or without posterior tibial tendinosis. So the calcaneonavicular ligament, the spring ligament, is a key medial restraint in the midfoot. If that gets torn, you get an adult acquired flat foot. Is that anything that you believe that, don't you?
Yeah.
Yeah. So that's sort of straightforward. So now let's just move a little forward. Let's forward to the first metatarsal phalangeal joint. What are the medial restraints of the first metatarsal phalangeal joint? Well, you have the abductor hallucis tendon. The abductor is the largest muscle mass in the intrinsic muscles of the foot. And does it adduct the hallux when you fire it? No, it actually inserts into the tibial sesamoid before it inserts into the proximal phalanx. It is a medial restraint that keeps the sesamoid in position. The medial sesamoidal ligament is a significant unknown force that to podiatrists that holds the tibial sesamoid in position and is a major ligament of the first metatarsal phalangeal joint. If that ligament becomes attenuated or torn, the tibial sesamoid can no longer be held in position, and it is the failure of the medial sesamoidal ligament that brings on incipient hallux valgus. Along with that, any tendon that inserts into the tibial sesamoid, which is the flexor hallucis brevis tendon, is another medial restraint structure. There are ligaments also from the sesamoids, like the plantar plate of the first MPJ. There are ligaments from the sesamoids that also are medial restraints if they insert in the sesamoid into the phalanx. The other medial restraint is an intact crista. So the first metatarsal axis of motion allows for dorsiflexion inversion and plantar flexion eversion. Michael Burns taught us that the last time he gave a lecture, and you know that from the literature. However, when there is a dorsiflexion inversion moment of the first metatarsal, there is interaction between the tibial sesamoid and the crista, which prevents the first metatarsal from actually moving in a dorsiflexion inversion motion. The ground reactive force creates a force moment, but it's resisted by all of these medial structures, and the inversion cannot occur unless there is a disruption of either the medial sesamoidal ligament or the tibial sesamoid crista interface. And that's why you'll see when you see dorsiflexion inversion on an axial view, you'll see on an MRI, for instance, you'll see inflammation around the crista. You'll see heterogeneous T2. You'll see heterogeneous signal in the tibial sesamoidal ligament, which means it's failing. The sesamoid is beginning to either erode or jump over the crista. So again, the abductor, when it is on the medial side of the first metatarsal, it's in a tunnel. It's when as you dissect through this, if you're operating in this area, you'll see that this large abductor hallucis tendon is attached intimately with the tibial sesamoid before it moves onto the proximal phalanx. And that tunnel and the insertion of the abductor hallucis tendon onto the sesamoid is critical, okay? And this is the medial sesamoidal ligament. I believe, and I think this is a critical issue, that this ligament, which is often dissected when you take off a medial eminence, often it is not even seen by the surgeon. It looks like just thickening of the capsule. And if you do not identify this ligament and utilize it to realign abnormally aligned sesamoids, you are looking for recurrence, and this ligament needs to be addressed in all of your bunion surgeries where the sesamoids are out of position. Now, I'll show you some where they look like they're out of position in the AP view, but they're really everted, torsional eversion of the metatarsal. In those cases, turning the metatarsal may be fine, and maybe it'll, as long as the sesamoids are in good position. But if you ignore this ligament and not find it and repair it after you take off a medial eminence, you are not getting the sesamoids where you want it. And I'm going to show you how you do that. I'm sorry. I'm going to answer that. Okay. So again, just an axial view showing an intact crista and mild bunion, sesamoids actually in what on an axial in fairly good position. If you can almost look at if you look at this axial view, it almost looks like the head of the first metatarsal. It looks like there's a little bit of torsion to that. If you just draw these lines to here and then look at the head. So I think there is some eversion or eversion torsion in this metatarsal. So this is different than a bunion where the sesamoid has jumped over the crista, and we'll go look at that. So this is a famous case that all medical students know about. This is a Phineas Gage. I don't know if any of you heard this, but anybody know who this guy was? This is taught to every medical student because it's a famous case where this fellow was working, I think it was in Pennsylvania, and got this bar that went right through his head and took out put a hole right in his brain. He walked around with this until they finally pulled it out. But this case demonstrated was they were able to find out what this area of the brain controlled, because this guy lived and they knew what part of the brain was injured and therefore could tell what the pathoanatomy, what happened when that part of the brain was removed. And so
did he get a bunion after it happened?
He did. He didn't, but his wife did. His wife did, and Mrs. Gage. So this is a woman who had, when she came to me, she had both feet look like this foot here. And she had a little bump, like a beginning of a bunion. So she had a minor bump. I injected her with depomedrol medially right over her, into her bunion bump. 3 months later, and excuse me because I took these off of a computer. This was the foot that was not injected. And this foot, 3 months later, had a bunion, dislocated sesamoids, and an IM angle, all from an injection on the medial side. So I looked at that and said, well, what the hell happened? How is that possible that all of that could happen? And I already told you what could have happened. Steroid injection into that sesamoidal ligament. If it ruptured, this is the result of that. IM angle opens, sesamoids move in one direction, the IM angle opens up, and there's a hallux valgus. So this was enlightening to me that could happen, and led me to look at what structures on that medial side of the hallux of the first MPJ could be involved with this. Not only that, but she had collapse of her medial arch after this injection. Okay, so that also, so the question is, does she have hypermobility and of the first MPJ secondary to having a bunion deformity? And does that destabilize the foot and allow for pronation? Well, in this case, it did. And so what's the etiology of that? What's the mechanics that allowed for that to occur? And I'll show you what I think could explain that. And that gets us to what's the etiology of first ray hypermobility? You know, is it the you look at the peroneus longus, and we're taught that the peroneus longus is a plantar flexus the first metatarsal, and allows for stability of the first ray. And I think to a certain degree, it does assist in the windlass effect. I think that it's because it inserts fairly close to the fulcrum of where the first ray moves. The closer to the fulcrum you are, the less power you have. So I think that we may be looking at the peroneus longus may not actually plantar flex the first ray as much as it does afford foot stiffness by means of pulling the medial cuneiform into what's called a close pack position with the middle cuneiform. So again, the first ray, the peroneus longus fires in mid stance. It comes across from the cuboid into the first metatarsal base and the cuneiform. And when it fires in mid stance, it's actually pulling the transverse arch and creating stiffness in the forefoot. And I'll show you this. The other thing is, I think hypermobility of the first ray is more secondary to instability of the first metatarsal phalangeal joint. And after you have failure of the medial ligaments, sesamoids that are over the crista, you then transfer your dorsiflexion inversion moment to motion, where you have the first metatarsal dorsiflexing and inverting when you look at an axial. And of course, pronation of the foot is also involved in that. That's why we get hallux valgus, because of unlocking of the mid-tarsal joint and pronation of the lateral column and supination of the medial column, which we'll talk about. So I want to talk a little bit about transverse arch stiffness. This is a concept that came from the mechanical engineers at Yale, and they published the paper in Nature, which is a really good scientific journal, about the transverse arch of the foot. And so basically the foot is has a three-point bending mechanism. You have the Achilles pulling up, you have the force of weight and acceleration pushing down, and ground reactive forces pushing up at the first MPJ. And so we're used to talking about the longitudinal arch of the foot and the structures which help hold the longitudinal arch. And that could be the PT tendon, the spring ligament, the peroneus longus to a certain degree, the plantar ligaments that hold the first MPJ. But there's a whole other way to look at that. And if any of you have any of you have $1 in your pocket? Do you have a wallet on you, Ryan or Josh? You have any money? Take $1 out, and I'll do it for you if you don't. The whole idea of a stiffness in the forefoot, if you take $1,
will a napkin do?
A napkin will do. Yeah, okay. If you take it and hold it at the end, they're looking at. If you look at this, it would take if you put 5 grams of pressure on this, you can see it's like a piece of pizza. What do you do when you eat pizza? You take it and you fold it in and you make an arch in it, right? You hold it, if you hold it on the end and make an arch like that, then you suddenly have stiffness in it, and it's 100 times more stiff than if you hold it on the end and just let it flop. So if you turn that upside down, the arch of the transverse arch of the foot, at the tarsal metatarsal joint, there's an arch there. Those bones are arched. At the distal end, they're all on the same surface. But that transverse arch, because of the dynamics of that arch, gives the forefoot stiffness. And you need stiffness when you push off. So the foot's a mobile adapter when it hits the ground, but when you resupinate, when your other leg is coming forward and you're resupinating, your foot needs to be stiff. And part of that is the transverse arch. And the transverse arch is pulled together by the peroneus longus. And I'll show you that. So what these guys did is they also looked at the ligaments distally, and when they actually cut between the metatarsals in a cadaver foot, the 3-point bending was cut in half, and so there's the arch of the transverse arch gives the foot stiffness. The peroneus longus obviously comes across. I just wanted so this is I got this from Mike Burns. This is out of one of Christensen's articles, but this is the peroneus longus. The lateral side is over here. So, and the peroneus longus, what does this do when it fires? Look at the cuneiforms here. There's an arch there. When this fires, it pulls the first metatarsal and cuneiform together, and that arch locks, and that gives the forefoot stiffness and the first ray as well, because the cuneiform now is pulled closer to the middle cuneiform, and that helps to lock that transverse arch. And so the compression of the transverse arch by the peroneus longus is probably more likely to give the foot stiffness and push-off power than plantar flexion of the first ray. So in the forefoot, you've got the deep intermetatarsal ligaments that hold the cross through all the metatarsals. The deep transverse intermetatarsal ligament inserts into the fibular sesamoid. All right. So if you've got attenuation of the medial sesamoidal ligament, and these sesamoids get the first ray dorsiflexes and inverts, and the sesamoids go laterally, you lose the tie rod effect, the tie bar effect that holds these metatarsals together. And understand that the first, second, and third metatarsals are medial column. If you think about the foot, the medial column is the talus, the navicular, the three cuneiforms, and the medial three metatarsals, and the fourth and fifth metatarsals and the cuboid and then the calcaneus are the lateral column. So in a pronated foot, the lateral column is dorsiflexing and everting. Now in closed chain, it's sort of different, but this fourth and fifth metatarsals can dorsiflex as the foot is pronated, and the calcaneocuboid joint axis is more horizontal. These two bones are moving in the lateral direction. These three actually have to supinate when the foot is pronated. Okay. So anyway, so there's a supination moment around the medial column. And again, if this guy here is the peroneus longus, the peroneus longus inserts fairly close to the TM joint. It's right on the fulcrum, which means it doesn't have much power. you know, on the distal end of the metatarsal. Can't really pull it all that well in a plantar direction, but it has a bigger force, a lateral to medial. I try to use this as a fulcrum, but again, it's the same thing. It's just, if your force is too close to the fulcrum, you can get a 10-year-old to pull on this and lift the car up. So what are the structures that stabilize the first metatarsal phalangeal joint? So again, this is an axial view, tibial sesamoid. This is the medial eminence. What makes a spur on the medial side of a tibial sesamoid? Like a calcaneal spur. What pulls on the calcaneus to make a spur? Well, what pulls on this? This is the result of chronic intermittent pull on the medial sesamoidal ligament. That is a critical structure that we have to deal with. And so this is just an example of what happens when you have chronic intermittent pull on your tibial sesamoidal ligament. You can develop a spur there, which is Wolff's law, just telling you that there's significant force from that ligament on that sesamoid trying to hold it in place. This is an MRI of a hallux valgus, okay? And what you can see, this is the flexor longus. You can see inflammatory inflammation around the crista in some intensity there. This structure here is the tibial, medial sesamoidal ligament, and the signal is intermediate. This little black right here is the collateral ligament. It's deep. The collateral ligament, which goes from the head of the metatarsal to the base of the proximal phalanx, that has normal intensity, low intensity. These structures here have intermediate intensity, and this, to me, you can see this tibial sesamoid starting to erode the crista, and there's inflammation because of that. Again, that just, to me, shows that the dorsiflexion inversion of the first metatarsal can create sesamoid crista interface problems. So again, what are the first MTP joint restraints? Plantar fascia, medial sesamoidal ligament, which is a critical issue, tibial sesamoid crista interface, flexor brevis, the balance of the adductor and the abductor holding the sesamoids in position, so that, and remember the adductor tendon, there's an oblique and a transverse head. The transverse head connects the medial column and the lateral column together, because it inserts all the way over onto the fourth metatarsal and into the tibial sesamoid. So when you have a pronated foot, you've got dorsiflexion abduction, eversion of the lateral column, supination of the medial column. The adductor transverse head is now pulling on the tibial sesamoid. And so that's part of the force that is creating your hallux valgus. You've got ground reactive forces that are forcing the first metatarsal in a dorsiflexion inversion manner, which is resisted by medial sesamoidal ligament until it's not. And so, and you have the peroneus longus compressing the transverse arch, giving you stability. So that's sort of the restraints of the first MPJ. Understand that the plantar fascial restraint is a weight-bearing restraint at push-off. So when we're looking at hypermobility of the first ray with the foot slightly plantar flexed sitting in a chair and the plantar fascia not weight-bearing, you're missing 25% or so of the restraint mechanism. The other 40% of stiffness of the foot comes from the transverse arch. So when you have, how do you get first metatarsal phalangeal joint restraint failure? Well, pronation of the foot is certainly a prime deforming force of the first MPJ, and that can come from various etiologies. It can be compensated forefoot varus. It can be equinus. It can be flexible forefoot valgus. Hypermobility of the entire foot from other syndromes like Ehlers-Danlos or some other hypermobility syndrome. But anything that allows for significant pronation of the foot puts significant forces on the first ray. So you lose peroneus longus with a pronated foot. You lose it, even though it inserts in the fulcrum. You lose the compressive force on the transverse arch. And again, you have increased dorsiflexion inversion moment resisted by the medial sesamoidal ligament, tibial sesamoid crista interface. With that, you get stretching, pulling on the medial sesamoidal ligament. That causes the medial eminence. Now, I do read that people are saying there's no such thing as a medial eminence. I've been looking at that for 40 years. I've been cutting them off for 40 years. You can't tell me that when I'm looking at something that doesn't exist. Of course, a medial eminence. It's not an X-ray finding. It is the result of chronic intermittent pull of the medial sesamoidal ligament, which, by the way, is as wide as the medial eminence. It's what causes the medial eminence. So you have, again, medial eminence formation, failure of the crista to resist sesamoid drift, and you have active pull of the deep transverse metatarsal ligaments because of abduction of the lateral column, and the sesamoid gets pulled out of position, leading to hallux valgus deformity. Once the tibial sesamoid breaches the crista, this allows for IM angle increase. You're not born with high IM angles. You have to walk. You have to have some deformity of the first MPJ. I would like to see an example of a 20-degree IM angle where the sesamoids are in normal position. I don't think that exists. And if it might exist, but it's the classic example of a high IM angle. The higher the IM angle, the more likely you have failure of the sesamoid crista, failure of the medial sesamoidal ligament, and then opening of the IM angle. And remember that as you get an increase in the IM angle, it's not necessarily just a deduction of the TMT joint. You can actually see subluxation of the first ray away from the second metcuneiform joint. And again, when you get sesamoid apparatus subluxation, you get failure of this deep intermetatarsal transverse metatarsal ligament to hold the metatarsals and hold the stiffness of the forefoot. So again, here's a crista. The crista's eroded. Here's your fibular sesamoid. Tibial sesamoid is on the lateral side of the crista. First metatarsal is dorsiflexed. And is that everted? No, it's inverted. Here's the crista, sort of what's left of the crista here. Here's a recent case of mine. Any guess at this IM angle? Josh, take a guess. You're unmute.
I'd say between like 15 and 20.
All right. Okay, 15, 20 degrees. I don't disagree. here's, if you look at this is the axial view of this. Look at this sesamoid in the interspace up here, tibial sesamoid lateral to the crista. That crista is not everted. Oh, the crista, actually, you may have torsion of the head and distal shaft on the metatarsal. It may have started in eversion, but to the ground, which is here, that first metatarsal is inverted. And so if you think you can do a lapidus on this and just put a joystick in and turn and invert, what would make you want to invert that more than it already is? Like Dayton says. I don't get it. Okay, I don't get it. There are cases where that's right, but this isn't one of them. Okay, this is, and so you would look at this and say, well, you got it. I mean, that's a 20-degree IM angle. Can you do a distal osteotomy on that and make this right? Yeah, you can, and I'm going to show you how. Could you do a lapidus on this? Yeah, if you wanted, that's okay, but you can't do it the way they're talking today, about leaving the pathoanatomy of the first metatarsal phalangeal joint as is and just turning the metatarsal. That does not work in this kind of a case. Now, you know that sesamoid ligament has stretched out or torn because it's got to come from here all the way around to here. So when you're fixing that, if you're fixing this, other than you've got to do something about that ligament to get these sesamoids back into alignment. You can't just push this if you just did an osteotomy distally and tried to move this metatarsal head laterally, look what you run into. That's not going to work. You've got to address all of the pathoanatomy of the first MPJ in order to make this bunion better. Okay. Okay, here's just a backed up view of this. And again, same foot. You can see it's dorsiflex and inverted to the ground. You can see the fibular sesamoid here. Look what's happening up here. Look at this. You're getting subluxation, not only of the first metatarsal cuneiform joints here, but the cuneiform is moving away from the second metatarsal. So this is hypermobility isn't just TMTJ. There's more to it than that. And you can, if you think this, if you've got another explanation, please unmute and let me know. You can certainly educate me, but for now, I think you're seeing what I'm seeing. So now here's a different case. This is a case she has she's got an early bunion, severe flat foot. From the back view, not too much in the way of eversion. So this is one of these what I call a high axis, subtalar joint axis is sort of high. So you more in the 60-degree angle. So you don't get so much eversion of the heel, but you do get some pronation and talar adduction. So, but this is the X-ray of that patient. So it looks like the sesamoid is out of position, right? And there's a mild to moderate hallux valgus, a little bit of a bump here. But notice on the lateral view, there's not much elevation of the first metatarsal. If you've got hypermobility of the first ray, don't you think you'd have some elevation of the first metatarsal on this flat foot? I don't know. I don't see it. But the axial view is interesting. The sesamoids are in good position. This is one of those cases where you have, I think you've got torsion of the first metatarsal, sesamoids are in pretty good position, and the dorsal plantar view shows that fibular sesamoid sort of out of position, but it's because you have an everted or torsion of the first metatarsal. So that's a case where, you wouldn't want to try and pull these sesamoids around or do any soft tissue releases and pulling of the pulling of the ligament back in position, because the sesamoids are already in position. How do you get hypermobility of the first metatarsal if the restraint system is still intact? So is there a valgus torsion of the first metatarsal? Yeah, there is, and there was a journal article, Journal of Foot and Ankle Research, where they took normal feet and hallux valgus feet. And in the normal feet, there was 8.6 degrees of valgus torsion, and the HAV feet, 36 degrees of valgus torsion. So there's no question, and this is sort of a newer concept over the last few years. There's no question that CT scans of the first metatarsal do demonstrate that in hallux valgus, there's an increase in torsion. That torsion means bony rotation of sort of the mid shaft and head to the base in a valgus position. So Kim and Foot and Ankle International showed that they had 138 feet, and then 20. They showed on CT scans that they had 19 controls of normal feet, and 25% of them had pseudo sesamoidal subluxation because of they called it pronation of the metatarsal, but valgus torsion of the metatarsal. So yeah, so you need an axial view on your bunions in order to know what to do. You can't just do a lapidus and do an invert it without knowing where those sesamoids are on an axial view, or a CT if that's what if you can get that done. So this is from the article, Oda and Nagura, basically showing their controls. They had 27 female cases with IM angles over 20 degrees. And they did their CT scans at 0.5 millimeters. And basically they showed the torsional angle in the control was 8.6. And on the hallux valgus cases, on average, they were 36. So clearly there is some etiologic factor, perhaps, when the head of the first metatarsal is rotated and in torsion. Now that's different than rotation at the TMTJ that Paul Dayton talks about. That there's somehow an eversion of an otherwise normal metatarsal that happens to be everted. I think they're inverted, to tell you the truth, most of the time. And again, just showing the distal. And by the way, if you've got on an everted first metatarsal, if you're a pronated foot and you've got a ground reactive force pushing on that everted first metatarsal and it's wanting to dorsiflex and invert, the more everted it is, the more pull there is on that medial sesamoidal ligament, the more likely you are to have failure of that ligament because it's already turned. And when the force is pushing the first metatarsal dorsiflexing and inverting, that ligament comes under stretch before this one would. So I think that torsion has a direct effect on the attenuation of the medial sesamoidal ligament. All right, so we're going to talk a little bit now about intermetatarsal angle. So, when you look at children don't have high IM angles. They have metaductus, but you don't see IM angles occur in bunions. As the bunion gets worse, the IM angle gets larger. So bunions, and I think there's a 3-to-1 female to male ratio, and hallux limitus, it's 3-to-1 male to female. And so, you have to wonder whether the biomechanics are sort of similar, and males get hallux limitus and females get hallux valgus. And of course, it's a Venn diagram. You can have it either way. But female joints in general are rounder. The crista is smaller. Ligaments have less tensile strength, and they've shown that in sports medicine when you have female basketball players tear their ACLs much more than men because the tensile strength is less. So what's the natural history of the IM angle? It's not congenital. I think there are abnormalities at the base of the first metatarsal which may increase IM angle. An os intermetatarsium, there are some lateral facets that you sometimes see. There's three type 1, type 2, type 3. They're just the size and width of them that can increase the intermetatarsal angle. The metcuneiform angle, although there's no one-to-one relationship between first metcuneiform angle and IM angle, if you have a high intermetatarsal angle, which should be about 10 degrees, by the way, if it's high, there may be you may have some increased tendency for IM angle increase. But it is strongly associated
Marty,
with sesamoid displacement and the
Marty,
hallux. Yes.
Your screen is frozen.
Yes.
We haven't advanced beyond the slide that says intermetatarsal angle, and you haven't moved for about 3 or 4 minutes.
All right. Hold on.
I'm not sure what's happening.
Okay. How about this? Can you see this?
You still aren't, your screen, I can't see you moving on your frame. Now, yeah, I can see that.
Oh, okay. Hold on. You see this screen? It says IM angle increase.
Yes, I see what now it says, what is the natural history of the IM angle?
Okay. Okay. And now I'm going to the next.
Okay.
How about that?
Yeah, there's something, I've
move?
got a very poor quality. I don't know about you guys, but I have a hard time reading that. Can you see that clearly, Paul?
No, it's very,
Really?
it's.
And
Yeah.
Marty isn't moving. So I wonder if it's something with his connection.
It's connection, yeah.
The photograph of Marty's not moving. His voice is okay. I can read that. That's big enough. I can read it.
All right. All right. So, well, I'll read it for you because I'm almost done. So what I wanted to say, the IM angle increases are strongly associated with sesamoid displacement and hallux abductus angle. And basically what that means is if you have a high HA angle, you've got retrograde force on your first metatarsal. But in order to get a high hallux abductus angle, you've got to have the sesamoid apparatus has to move laterally, and the first metatarsal has to move medially, and then you get it's almost like it's like a little hammock. You know, you have the ligament, the two sesamoids, and the other ligament, and that all moves together in the frontal plane, which pulls the toe into valgus and abduction. The bigger that angle is, the more the first metatarsal moves medially. So again, you can have structural or positional IM angles. Angular deformity of the first metatarsal is really not found. I mean, you can bisect the base of the first metatarsal, do a bisection of the shaft, and it's basically parallel. So when we do metatarsal osteotomies, whether it's a base or even distal, whatever we're doing, it's not at where the deformity lies. So, and we've recognized recently that there are torsional deformities of first metatarsal. They are significant. Okay. Let me know if this doesn't move. Did that move?
Nothing.
Did it move?
No.
Huh.
No, it's not moving. And you're not either. You've been in the same position for the last 15 minutes. Now the slides are going.
Now it says how to enhance your bunionectomy procedures.
That's where I want to be. All right.
Okay.
So this is level 5 expert opinion. It's my opinion. Okay. So osteotomies, proximal or distal, arthrodesis of the TMT joint. For me, those are ancillary procedures for the repair of hallux valgus. Okay. The most important procedures that you do are to reestablish the anatomy around the first metatarsal phalangeal joint. If you've got a long first metatarsal, sure, you should shorten it. If you've got some PASA problem and you want to correct that, absolutely, that's necessary. Arthrodesis of the TMT joint, that is fine if that's what you like to do. But even if you do that, if you do not address the distal soft tissue imbalance, you can get recurrence, because the TMT joint fusion does not necessarily stop the first ray from moving away from the second, unless your construct puts a screw across that. So this didn't move. My internet's stable. Right. All right. Here we go. So this is in podiatry. If you don't do an osteotomy or fusion and you're doing soft tissue work, the comment is always, well, it's only soft tissue, like your brain and your heart. It's really not that important, So, the idea of track bound joints, they're track bound until you do an adequate soft tissue release. Like a club foot is track bound until you either cast it or release it. Hypermobility of the first ray, everybody wants to do a lapidus. Fine, but I think you can correct hypermobility of the first ray by reestablishing your sesamoid position, so that your plantar fascia windlass effect works better, and that by itself will give you stability of the first ray. So again, anything that you can measure that's deformed on the bone, happy that you can go and fix it, but that's not enough to get what you need from a bunion deformity correction. So I want to talk a little bit about this procedure, not so much that you should do it alone, but the idea of what the correction of these pathoanatomy problems can look like. And hopefully I can show you some of these, so that when you're in the operating room with your attendings and you're doing bunion procedures, you'll know that what you're missing, unless they actually do some of these things. So this sling procedure dynamically realigns the sesamoid complex, reduces positional increases in intermetatarsal angle.
So we're still a slide or two behind you.
Hold on. All right. Good, so I can.
So I've got a slide now that says you want the truth, you can't handle the evidence.
I think he's trying to get a video.
Yeah, I know, and I'm not going to be able to do what I want to do, I don't think. I wanted to get a video to play, but it's not going to play.
Yeah,
I don't know why.
I don't think you have enough bandwidth.
Yeah.
I think it's something with your connection. Yeah.
Yeah, that's too bad, because I have other video that I'd like to play that I'm not going to be able to. All right. So here's my, if you want to do evidence-based medicine, you can pick and choose, just like the Bible, you can pick and choose the kinds of things that agree with you. So these are the things that are in the literature that I picked out, because some of it I wrote and some of it I used while I wrote. So the 1928 McBride transferred the adductor to the metatarsal neck, did a fibular sesamoid, closed down IM angles. This is the second article, Alvarez Gould in Foot and Ankle, 1984, is really an important article. And if you want to read anything, if you can find this article, it talks about the pathoanatomy of hallux valgus and really emphasizes the ligamentous structures. And this, I thought, was a watershed article for me, looking at correction of hallux valgus. And then we published a couple of articles, one in the Journal of the American Podiatric Medical Association in '86, just talking about positional increase in IM angles and the correction thereof. So there's other literature that basically says transfer of the adductor does nothing. So Foot and Ankle Specialties, Rodriguez looked at 25 or 30 cases, did adductor transfers to the capsule of the first MPJ laterally to the medial capsule. There was no difference in tibial sesamoid position, HA angle, IM angle. But what they didn't do is they didn't isolate the sesamoidal ligament, and they didn't do an active reduction of the tibial sesamoid. So I'm sure that they didn't find any difference, but I also know why they didn't. So these are sort of some of the and I'm going to show you these radiographs, but we measure 4 things to see if we can find which of these intermetatarsal angles are positional versus structural. So one is Marty, the distance between the first metatarsal.
We're not seeing the x-rays.
We're still seeing the slide that has the blank.
No, I didn't show you.
Okay.
Really?
Now we're at one that says radiographic parameters.
All right, that's where
selective EMB.
All right, so, and I'll show you these. All right. I'm going to show you some of these let me know when you see a radiograph.
Not yet.
I'm sharing my screen. I don't know why
it's all blurry.
Why it wouldn't show you that.
We've got a blurry screen with the Pressman article at the bottom. Now we're back to the one that's got the video. Now we're to the one before Pressman. It's the effect.
It's just slow. It's just,
yeah. Radiographic parameters.
All right. All right. I'm going to wait a minute. I'm going too fast. Let me know when you see an x-ray.
I will. Got one. So now I've got
I'm looking at it.
I've got an x-ray now showing the distal facets of the first cuneiform.
Okay, so that's where I am. Okay, so I think it's just it's slow. So when we looked at these parameters, one of my residents was a mechanical engineer, and we sat around and we tried to figure out what parameters to look at. And of course, he helped me look at some of these things. But one of the ones that we found when we looked at normal feet versus bunions with IM angles is that in a normal foot, the space between the first metatarsal base and the second metatarsal is about 1 millimeter. But in feet that have high IM angles that are positional, you see motion or the result of motion of the first ray moving away from the second metatarsal. And so you get this metatarsal split distance. And if it's 2 or 3 millimeters at the base, the larger it is at the base, you can imagine as you take that angle out, how the IM angle will open. So this was one of the parameters that we looked at. And when you correct these without osteotomy, that metatarsal split distance reduces. And I'm going to show you this. All right. So that's one criteria. I'm going to wait a minute till you catch up.
Now we've got an AP view showing that. I can see the first thing.
So the other thing we looked at is, are there any deformities in the first metatarsal, and how would we know? Are there any, bending, angular deformities? So we basically did a perpendicular bisection of the base, and then a bisection of the shaft. And no matter how many times you do this on whatever bunion you see, there's really very minimal, if any, angular deformity of the first metatarsal. So we call that the metatarsal deformation angle. And it's under 8 degrees, but generally it's around 0. And all that means is whenever you cut a first metatarsal and move it for a bunion, you're really not, unless you're doing it for length or to close the IM angle, you're not really changing any angular deformity. And then, of course, the metatarsal cuneiform angle, and that's a standard measurement. When you look at a metatarsal cuneiform joint on an AP view, sometimes you see it looks like there are 2 joints there because the distal end of the medial cuneiform has a shelf that comes up and over the joint. So the more proximal joint is on your AP view is where you draw your line, and then you draw a line through the base of the first metatarsal, and the normal is 10 degrees. Anything higher than 35, and I don't, may prohibit IM reduction because of that angle, but there isn't a one way. If you have a 35-degree metcuneiform joint angle, that doesn't mean you have a 35-degree IM angle. It's not one-to-one. Okay. So in this, here's a case. This is a positional increase in the IM angle because the tibial sesamoid is on the lateral side of the crista. The fibular sesamoid is in the inner space. There's a normal metcuneiform angle. There's a normal met deformation angle, and there's space between the first and second metatarsals at the metatarsal split distance. So this was done without osteotomy. The IM angle was now 6 degrees. Sesamoids are in perfect alignment. And look what happened at the base here. It's actually tucked. It's tucked under the second metatarsal. And so you can close, this IM angle is about 14, 15 degrees. You can, with proper soft tissue realignment around the first MPJ, adductor tendon, reestablishing the medial sesamoidal ligament, and pulling the sesamoids back into alignment, you can reduce an IM angle to normal without osteotomy or TMT joint fusion. So again, axial view, you want the tibial, to do an adductor transfer, you want the tibial sesamoid to either be on or lateral to the crista. If this was a everted first metatarsal and the sesamoids were in perfect position, then this procedure would not be indicated. So the indications, again, tibial sesamoid position, 3 or greater, metcuneiform angle less than 25 degrees, normal metatarsal deformation, and you need at least 2 millimeters or so of metatarsal split distance, and no other osseous deformities unless you want to fix them. But if you're going to do this, it's really a modified soft tissue like a McBride with an adductor transfer. But what's different about this is that you actually find the sesamoidal ligament and you separate it and you titrate you transfer it dorsally and attach it to the adductor. I'll show you how you do that. Now, if you have a congenital variant, obviously all bets are off. This is not the kind of bunion that we're talking about. So again, this rebalances the sesamoid, decreases IM angles that are positional. You get active reduction. It's one thing to go and do a lateral release. That's passive. That doesn't mean that you're going to get reduction of the sesamoid. This is active reduction by pulling the medial sesamoidal ligament up and pulling the tibial sesamoid back into position. And by doing that, you derotate the toe out of valgus, you decrease retrograde forces, and even more importantly, when you do this transfer, the adductor tendon comes from plantar to dorsal, as does the medial sesamoidal ligament, and you get this sling, which acts as a check rein to dorsiflexion of the first ray, which decreases hypermobility. Now, let me see if I can show you how this is done. All right.
You look like you're back to, looks like you're back to full resolution now. I would bet your video would even work. Okay,
I have some videos coming, so we'll see.
Okay.
So this is the dissection of the adductor, the oblique head. and when you go and you take the bump off, you do what you're going to do. Then when you do a horizontal incision right above your sesamoid and dissect out your adductor, tag it, and then make a tunnel underneath, right on subperiosteal tunnel, right at the neck of the metatarsal. And you pull this adductor tendon dorsally and underneath the periosteum of the first metatarsal. And of course, obviously, underneath the EHL. If you look right here, can you see my pointer?
Yep.
Yeah, so that is the adductor tendon right at the medial cortex. So you can get enough length on that to bring that adductor tendon right to the medial side of the metatarsal. And this is a absolutely critical step. And I think in anybody, if you don't do an adductor, if you don't do anything else, you should do this. You should separate the medial sesamoidal ligament from the capsule, and it is separable. And you can, even if you put a stitch in it and pulled it up and sutured it to periosteum or just attached it to pull the sesamoids around, that will do more for you than any capsulorrhaphy, U-shaped, or any kind of capsule correction that you want to do. This is more important because it brings the sesamoids back on in alignment, gets your plantar fascial attachments directly under the first metatarsal. So when you do this, your assistant holds the capsule. You, the surgeon, reach in and grab the white fibrous ligament, and you take your 15 blade and just sort of tease it apart, and you get this really thick, very strong ligament. Here's capsule. Here's the ligament. Okay. And look how wide that is. That's as wide as the medial eminence. And that inserts directly into the tibial sesamoid, and the AB and the abductor is right there at the bottom of this. So then you hold the toe, you pull the toe straight, you close down your IM angle, you can have somebody pull it together, and you suture this sesamoidal ligament to the adductor tendon. That's the sling right there. You can use non-absorbable if you like. And what this does do is when you pull up on that sesamoidal ligament, it derotates your hallux back into normal position. You don't have to do an osteotomy. You don't have to do a lenticular capsulorrhaphy. That sesamoidal ligament by itself undoes the valgus rotation in the frontal plane because you're pulling it in the frontal plane, and you're getting frontal plane correction of your sesamoid apparatus along with the toe.
Okay.
So this is a horizontal incision through the lateral sesamoidal ligament. I'm just going to grasp the adductor until I can see the sesamoid. My hand's in the way.
No, I can see it all right.
Yeah. Okay, turn it off. All right, I'm just placing the knife on the lateral side of the sesamoid, which is in the inner space, and taking down the adductor off the sesamoid. This is the adductor right here. This is the J incision, and I'm just going to pull this back off the sesamoid. And I need a 2-0 vicule. I'm going to tag this for transfer. Here's the sesamoid sitting in the inner space right there. Okay, thank you. Okay, we're just tagging the adductor for transfer. Just cut that. And what we're going to do is transfer it under the periosteum over to the medial side, ready to be sutured to the adductor, to the sesamoidal ligament. There's the adductor right there. Okay, thank you. Yeah, is it on? Mm-hmm. Okay, so now I am separating the sesamoidal ligament from the inside of the capsule. The sesamoidal ligament is white fibrous. The capsule is fibrous tissue, but not as thick. And this sesamoidal ligament attaches right to the tibial sesamoid. And when you pull on it, it will pull the toe straight. And I will show you that in one moment. Okay. Okay. Okay, you can see where the toe is when you pull on this. Okay, thank you.
Yep.
Okay, I am suturing. This is the adductor tendon. I'm putting a stitch through the adductor tendon. And this is the sesamoidal ligament. And I'm putting a stitch through that and attaching those in a sling fashion. You can let go of that. Hold the toe over and push the IM closed. Okay. This is a non-absorbable suture, Ticron, and this is the sling that holds the adductor to the sesamoidal ligament in a sling fashion and helps to hold it up. All right. Okay. Stop. This is tying the sesamoidal, you don't have to do that, sesamoidal ligament to the adductor.
So I call this an enhanced Austin bunionectomy. I mean, you can use this technique of adductor release or adductor transfer to the sesamoidal ligament with any distal osteotomy. You can do it with a lapidus. I think it's a mistake not to address all of the pathoanatomy that exists around the first MPJ. If you leave all of those structures and think that this is going to get better by turning the metatarsal, I think you're in for a problem. So again, I get back to what I said in the beginning. This structure is the most important medial restraint that there is on the first MPJ. It's uniformly ignored by most podiatric surgeons. And if you actually can get yourself to go find this and to utilize it to pull sesamoids back into alignment, to reduce some of the retrograde IM angle, your bunionectomies will work better. If you're just taking the bump off and not repairing this, the reason why some of these distal osteotomies or Aikens or McBride's fail is because the surgeon cuts this medial sesamoid ligament, the significant medial restraint of the first MPJ, and never repairs it. And that, I think, is a classic mistake. All right, so points to remember from this. Sesamoid alignment equals stability. You got to have axial sesamoidal views for your bunionectomies so you know whether or not to do whether it's everted, whether it's inverted, where the sesamoids are. IM angle is mainly positional. It's a positional deformity, and it's reducible. Hypermobility is not some type of Ehlers-Danlos syndrome attacking only the first TMT joint. Okay, it's not it is, I believe, a secondary phenomenon from pronation and from loss of first MPJ stability. And again, as we just looked at this bunionectomy, most of this was soft tissue. Soft tissues are important, like your brain, like your heart. After all, they're soft tissue too. Okay, thank you.
I'm going to unmute everybody if anybody has any questions. I will be making a video from this. I did record it and put it up on YouTube in the next day or two.
Okay.
So can you hear me, Marty?
Yes.
So that's pretty much the same way I always did my transfers, except I did not separate the ligament from the capsule. I made my capsulotomy at the top of the ligament and took the ligament and capsule down together to get to the medial aspect of the hip.
Yeah.
And then when I put my suture in, I put it through the ligament and the capsule and visually looked at the amount of reduction it was going to take to get the tibial sesamoid in the groove and then sutured in that position.
I love it.
The adductor transfer just like that.
Yeah. Yeah. I think the modern approach to bunionectomies, which I read more and more about, and ignores the pathoanatomy at the first MPJ. And if you do that at your own peril.
Anybody else have any questions? Comments? All right, thanks everybody. Thanks, Dr. Pressman. It was great.
Thank you.
All right.
Thank
Okay.
you. Thank you.
All right.
Dr. Pressman.
You're welcome.
Thank you.
How do I get out here? Okay.